This continues the video series on head impulse testing. Part 3 provides suggestions for performing the test effectively. It also describes some of the possible artifacts and methods to avoid them. First, remember that this presentation highlights some of the important aspects of the test procedure, but it's not a comprehensive guide. For that, you should read the manual and review other instructional videos on icsimpulse.com. Also, the procedures described here are not the only way of performing the head impulse test successfully. As more experience is gained, each clinician should develop his or her own optimal test procedures. Of course, these methods should be based on the physiology and interpretation rules that were outlined in Part 1 and 2. First, prepare the area where you will be performing the test. Place a fixation target on the wall at least 1 meter from the patient. The distance does not have to be exact and can be greater than 1 meter. But if it's less than that, it could cause a parallax effect and disrupt the calibration. The test should be performed in fully lit room so the patient can see the target. Also, in order to decrease the chance of pupil detection artifacts, it's desirable to have the pupil size as small as possible. So low levels of lighting should be avoided because it can enlarge the pupil size. But avoid setting the patient where there's too much background lighting. The light can reflect off of the mirror and distract the patient. In fact, you can place a panel or a drape behind the patient, especially over the right shoulder, to prevent the light reflection. For the same reason, it's best to place the laptop behind the patient's left shoulder. That way the examiner can monitor the test progress without the laptop screen causing any reflection. Finally, it's a good idea for the examiner to sit at the patient's seat and recreate the test condition. That way he or she will be aware of any potential issues that can affect the test. Before starting the test, examine the goggles and insert a new face cushion. Make sure that the mirror is clean and free from any fingerprint spots. The goggle fit is very important. As they are placed on the patient, the strap should be as tight as possible. Before tightening the goggles, open the patient's eye and slide the cushion underneath. This will keep the eye open and will help reduce pupil detection artifacts, especially in patients with droopy eyelids or with long eyelashes. Examine the goggles and make sure they're matching the contour of the patient's face. Remember to clip the cable from the goggles to the patient's clothing. The clip should be placed such that there's no resistance or pull on the cable during head movements. That usually means clipping the cable to the right side of the patient. Ask the patient to look straight ahead at the fixation dot and adjust the green box. This box is called the region of interest, or ROI. Move it so that the pupil is at the center of it. If the pupil moves outside of this area, the camera will lose track of the pupil and this will cause artifacts. So it's important to center the pupil initially and if necessary, repeat that throughout the test. Click on the pupil location mode and adjust the threshold until a clear image of the pupil is displayed without any other white marks. You can use auto threshold for that purpose, but sometimes it's a good idea to fine-tune the image manually. Move the head gently side to side and up and down to make sure that the pupil stays within the video screen and no other white spots appear on the screen. This will give you an idea about the amplitude of the head impulses that can be performed without causing artifacts. If the patient has eye makeup and it's showing up as white spots on the video screen, move the ROI slightly to one side to avoid this problem. If the patient has large pupils, shine an LED light on the eye to reduce the pupil size. As mentioned before, smaller pupil size will reduce pupil detection artifacts and will allow greater range of head movements. Now that we're ready for the test, ask the patient to look straight ahead at the fixation target and turn on the laser lights. Adjust the head position to place the fixation dot between the laser dots. Then click on Run to start the calibration and ask the patient to follow the dot as it moves from side to side. The calibration process is usually very short if the patient is performing the task correctly. You should see the eye moving side to side and spikes appearing on the real-time trace window. And here's the same thing with the grayscale image of the eye. Once the calibration is successful, you do not need to recalibrate for the rest of the test session. Before beginning the actual test, the head should be moved side to side slowly to make sure that the eye and head movement tracings on the real-time trace window match as closely as possible. If not, the calibration is not accurate and should be run again. Here's an example of a good calibration where the head and eye velocities match. Here is an example of a poor calibration where the eye velocity is smaller than the head velocity. And here is another poor calibration where the eye velocity is greater than the head velocity. For the last two cases, the calibration should be repeated. In rare cases, a patient may have catch-up saccades during the calibration check. In these cases, the patient may have cerebellar and vestibular dysfunction, and the test results should be interpreted cautiously. Once the calibration is acceptable, click on Accept to begin the test. It's a good idea to always start with lateral testing. For RALP and LARP, it's necessary to change the ROI. By starting with lateral testing, you can avoid unnecessary changes to the ROI. Before starting the test, perform a few practice head impulses and make sure that the patient is keeping his or her neck completely loose. Throughout the test, the patient's head movements should be completely under the examiner's control. The default number of required head impulses is 20 for each direction. For optimal testing, do not change that until you have more experience. Collecting fewer than 20 impulses is not likely to give uniform coverage for the range of necessary head velocities. Throughout the test, pay attention to the feedback that the software is providing. This will help you improve your technique. Modify your technique if the head impulses are too slow or have too much overshoot. Try to match the head velocities to the gray tracings in the impulse window. They represent ideal head impulses. If too many impulses are getting rejected, stop the test and try to determine why the impulses are not being accepted. Again, throughout the test, pay attention to the pupil image and readjust the threshold when there's too much artifact. If the pupil moves too far to one side of the video screen and disappears, either the impulse amplitudes are too large or the starting position of the head is too far to one side. Make the necessary adjustments to the amplitude or the starting position so that the pupil stays within the ROI. Some patients blink during the exact time that the head impulses are being performed. If necessary, remind the patient to refrain from blinking. It's important to avoid moving the skin or letting your hands slip on the patient's hair. To do the lateral head impulse test, stand behind the patient and hold the head gently without touching the strap. In theory, the head should be rotated down about 30 degrees before performing head impulses, but in practice, head rotation of less than 20 degrees is preferable. This prevents the eyes from moving too far up in the socket. In fact, some examiners do not rotate the head down at all. That's quite acceptable because the intensity of head impulses delivered to the lateral canal is not much affected by the head angle. It should be noted that the head velocities in this animation and the others that follow are not realistic depiction of actual head impulses. Actual head impulses are usually much faster than what's shown in these animations. Every so often release the head. That prevents pressing the neck down unintentionally. As was discussed previously, head impulses consist of rotating the head right or left unexpectedly using small amplitude, high velocity, high acceleration movements. Try not to move the head side to side repeatedly. Instead, randomize the direction and timing of the head impulses. After each impulse, pause momentarily, about a second, so that the patient can refixate on the target. Also, do not return the head too quickly back to the center. This will cause an overshoot, and the software will display a warning message. In general, there's no need to bring the head back to the center every time. After each impulse, observe the velocity of the last one. This is represented by a white dot on the left-hand side of the impulse window. Adjust the amplitude of the subsequent impulses so that the head velocities uniformly cover 100 to 250 degrees per second for both right and left directions. For RALP and LARP, ask the patient to look straight ahead and click on center. Then rotate the head to the right for LARP or to the left for RALP. This example shows the head rotation for LARP. Observe the head position in the controls window. When the head is turned 35 degrees, the color changes to yellow. When the angle is 45 degrees, the color changes to green. Ask the patient to keep staring at the target as the head is being turned. This will result in the eyes moving the same amount as the head, but in the opposite direction. The purpose is to keep the gaze direction in the plane of the tested canals. With this gaze direction, the eye movements should be purely vertical and no torsional eye movements should be generated. You will always need to readjust the ROI after positioning the head. Otherwise, the pupil will not be at the center of the video screen and will not be correctly detected. The reason that the head is turned close to 45 degrees in LARP and RALP is so that the stimulation can be restricted to just two of the vertical canals. In the most common method for testing LARP and RALP, the patient looks straight ahead and then the head is turned close to 45 degrees to the right or to the left. This video shows the method for LARP where the head is turned to the right. This is somewhat of an extreme head position and may cause discomfort to some patients, especially the older patients. In such a case, patient safety has to be considered first. So if you do use this method, do not rotate the head more than what's comfortable to the patient. When the head turn is not close to 45 degrees, in the interpretation of the test, one has to consider the possibility that the other two vertical canals that are not supposed to be involved in this test may be contributing to the response. A somewhat more comfortable alternative is to rotate the chair 45 degrees instead of rotating the head. The target should remain in the same position and the patient should be instructed to stare at it. The ROI should be adjusted as before and the head impulses should be delivered in the same plane as before. For LARP and RALP testing, head impulses should be delivered vertically in the sagittal plane. Here's a mannequin head to demonstrate one method of doing RALP and LARP. After turning the head, put your dominant hand over the patient's head with your fingers pointing at the target. Your other hand should be under the patient's chin to control the direction of rotation. But do not use the hand on the chin for moving the head because it may move the skin and create artifacts. Instead, move the head using the dominant hand with the fingers moving directly toward or away from the target. Head velocities for LARP and RALP should be around 50 to 200 degrees per second for both up and down impulses. Remember that the gaze direction must always remain aligned with the plane of the tested canals. This next slide shows the plane of head movements for LARP for either turning the head or turning the whole body. Here's the same thing for RALP. Notice that the plane of head movement is the same. The only difference is the orientation of the torso. Many of the same principles for lateral testing apply to LARP and RALP as well. For example, pause momentarily after each impulse. And again, no need to return the head to center every time. Randomize the direction and timing of impulses. Do not move the skin or let your hands slip on the patient's hair. If the pupil moves too far up or down on the video screen and disappears, either the amplitude of the impulse is too large or the starting position of the head is too far up or down. Again, make the necessary adjustments during the test. If a dark spot appears in the corner of the eye, either shine a light on the eye or move the ROI slightly away from the dark area. During the test, look at the real-time trace window to make sure that the head velocity tracings are changing only for the plane that's appropriate for LARP or RALP. For example, this particular tracing for LARP does not represent a good head impulse. Notice that in addition to the blue tracing that represents the head velocity in the LARP plane, there's also a substantial amount of head movement in the RALP plane. That's represented by the purple tracing here. If the deviation is too much, you will get a warning message that says wrong plane stimulated. This type of feedback can be used to perform the test more accurately by limiting the head movements to the planes of only two canals. Here are a few examples of artifacts that can happen during the head impulse test. The most common artifact is caused by loose and poor-fitting goggles. The goggle slippage usually appears as the activity in the eye velocity tracing that leads and occurs before the head velocity. These trials should be deleted, and if there are too many of them, the test should be repeated. Another artifact is caused by bumping the goggles during head impulses. This type of artifact is particularly troublesome because the tracings may resemble a covert saccade. This type of artifact can be avoided only with practice and careful administration of the test. Another artifact is related to the pupil detection issues. If the patient blinks or if the camera loses track of the pupil momentarily, the eye velocity tracings will show very sharp spikes that often go in both directions. By observing the pupil location during the test and adjusting the head impulse delivery method, one can avoid this problem. After a good head impulse, the head comes to a complete stop without any overshoot. This is an example of a test with minimal overshoots. But sometimes the head bounces back and creates an overshoot, as shown here, with the head velocity going in the opposite direction at the end of the head impulse. This can create an artifact because during the overshoot, the response is mediated by the opposite canal. For example, this patient has a left-sided lesion, but you can see a catch-up saccade in the opposite direction during the right head impulses. Of course, this is partially due to spontaneous nystagmus, but the lesion of the left lateral canal may also contribute to the presence of this catch-up saccade. A few other issues should be kept in mind for head impulse testing. First, The test should uniformly cover the range of optimal head velocities. If the head velocities are too low, catch-up saccades may not be present and a unilateral weakness may be missed. Also, the range of head velocities should be approximately the same for both directions of head impulses. Finally, as discussed before, one should be careful to deliver the head impulses in the appropriate plane for lateral, RALP, and LARP tests. This concludes the third part of the video presentation on VHIT. The next part will concentrate on the clinical application of the head impulse test.